Hi, I'm Dr. Raj, and it's time to go beyond the pearls. So we are a 34-year-old woman is evaluated for amenorrhea, headaches, and fatigue. She reports that from the time of her menarche about 2.5 years ago, her menses were regular and predictable. Then, at that time, her menses became irregular, then stopped 6 months ago. She had a few hot flashes and fatigue. She had noted some galactorrhea. She began having headaches 2 years ago. In addition, she notes blurry peripheral vision. The rest of her medical history is unremarkable, and she takes no meds. On exam, vital signs are normal. BMI is 21. A white, milky substance is expressed from her breast bilaterally. Ocular movements and cranial nerves are intact. There's no stigmata of a Cushing's disease or acromegaly. They do an MRI, as they should, and it shows a 2.4 pituitary tumor that elevates the optic chiasm and surrounds the left carotid artery. Which of the following is the most important treatment? But first, labs are important. Let's take a look at what we got. We got a cortisol in the morning. That is normal. We got an estrogen that came back normal. An FSH and LH are both normal. TSH is normal at 1.1. But wait a minute, what is in that bolded red? Prolactin. And I got to tell you, folks, that is immensely elevated at 472. Putting all this together, which of the following is the most appropriate treatment? Take a look at the choices. I'll let you kind of marinate that for a few seconds. But how would I approach this? When I look at this, I know what you're thinking. This is most likely going to be what? Prolactinoma. And how do we treat this? Oh my God, there's an elevation of the optic chiasm. Should we do radiation? The answer is no. Do we do radiation in general for prolactinomas? Maybe sometimes. It's not first line. It's not second line, but this wouldn't be a good choice in this particular case. What about B, octreotide? Somatostatin. It's an inhibitory hormone. And if I were to use this, what endocrinopathy would this most likely be the medical treatment of? That's right, acromegaly, but this is what? A prolactinoma. So it really goes down to, are we going to give carbegoline, choice A, or are we going to do surgery? And the answer is, you're going to do medical therapy first, even with some of the neurological deficits. And let's kind of talk about that even further. So what is going to be the bigger picture here? What is the differential of hyperprolactinemia? So, of course, we always think about the anterior pituitary itself. Is it that prolactinoma, otherwise known as what? A lactroph adenoma, because remember the prolactin is going to be secreted from those lactroph cells. Could it be a problem with the hypothalamus? But anytime you think about a prolactinoma, 3 hormones have to come to mind. Number 1 will always be dopamine. So do you guys remember that prolactin is under inhibitory control from dopamine? So anything that blocks dopamine, and what drugs can do that? Your antipsychotics, both your typical ones like haloperidol, your atypicals like quintonapine, which is Seroquel, Geodon, Abilify, to throw up a couple brand names there, they inhibit dopamine. And of course, a very common medication is metoclopramide that we use as a pro-motility agent in our hospitals. The other hormone that comes to mind is thyroid. Why? Because thyroid-releasing hormone, TRH, is a direct stimulant of what? Prolactin. So we always want to evaluate thyroid function. The last hormone that comes to mind is estrogen. So anytime you have elevated levels of estrogen, that increases prolactin secretion. And that's why if you're in the reproductive age, we always get a what? Pregnancy test. And the last thing I wanted to mention is always going to be things like chronic renal failure. It's in many board review books. And why does that increase prolactin? Well, there's no clearance of our hormone. So now that you made a diagnosis that it is a prolactinoma, well, how does that present in males and females? Well, in females, like in the vignette, they have problems with their period. They could have galactorrhea. They could have osteoporosis. But if you have neurological deficits, what is the classic one in all board review books? You get bilateral temporal hemianopsia. So please look for that on your board exams. In males, how does a prolactinoma present? Well, impotence is very common because males are not going to get their impotence evaluated. They commonly get focal neurological deficits. They get visual field deficits. So it is sad. So bringing it all together, how do we evaluate a prolactinoma? Remember, female reproductive age, get a pregnancy test, get a TSH. You definitely want to check a prolactin level. And what is the take-home message? The level of the prolactin, the higher it is, the more highly sensitive it is for a prolactinoma. And of course, imaging would be necessary, and MRI is a very reasonable choice. And to kind of bring it, the last thing was in the question, how do we treat it? Look at my slide right here, medical therapy first. Even when there's signs of mass effect or neurological deficits, people with prolactinomas are very, very sensitive to medical therapy. And what are those medical therapies? Well, based upon the science, you want to give a dopamine agonist. And there are 2 dopamine agonists that are FDA approved. Number 1 is the historic bromocriptine. But you have to dose it multiple times during the day. There's many side effects. So another alternative would be carbegaline, which is something that will be dosed not as frequently, better compliance, drops the prolactin level. So remember, medical therapy first. If they're not responsive, you could think about surgery, such as transsphenoidal surgery if possible. And if both those fail, then I would think about radiation. So I hope you enjoyed this walk through prolactinoma. I'm Dr. Raj, educating you today for a better outcome tomorrow. To get more information like this, see me in my board review course at the Pass Machine or go to my website, beyondthepearls.net.